Oops, I don't know what I did. Kavita, okay, fine. Hi, good morning, everybody. Welcome to this e-quiz this morning. So obviously, you know the format of the quiz. Interaction is the key, and the quicker you kind of give me answers, the more questions we can go through. So try and be quick and do answer. Don't wait for your friends to answer. Okay. So this is our first question. So what is the spot diagnosis in this patient? Any answers? Very good. Okay, so this is a patient with situs inversus and dextrocardia. So as you can see, the heart is on the right side of the chest. You can see the chest X-ray is labeled as well to indicate that this is the right. And the apex is also pointing to the right. And the stomach bubble is quite clearly seen in this X-ray and is also to the right, indicating that it is not just dextrocardia, but situs inversus as well. What is the other thing you can see on this X-ray that is important? What else can you see? Another piece of information. Anything else? What are these? Correct. So these are the sternal wires. So this is a post-operative patient. Okay. So what is the incidence of dextrocardia in general population? Anybody? Is it 10%, 30%, 1%? What is the incidence of dextrocardia? No answers? Take a guess. Just a number. What do you think? Come on, guys. No answers. Okay, so the incidence of dextrocardia is less than 1%, okay, in general population. So what is more associated with congenital heart disease? Dextrocardia, situs inversus, or isolated dextrocardia, that is with situs solitus and dextrocardia? This you should know. What is more associated with congenital heart disease? Correct. So isolated dextrocardia or situs solitus and dextrocardia is more associated with congenital heart disease. Usually situs inversus and dextrocardia, the heart is actually structurally normal. Okay. Right. So we move on to this question. The next question. This is an echo loop. What can you see? What can you see in this echo? It's a 4-chamber view of the heart. The chambers appear to be of normal size. Quick. Correct. So, well, so what you see is that there is some collection outside the heart in the pericardium, okay? But it is not the normal consistency of the usual pericardial effusion that you see. It is quite thick and does not appear to be clear fluid. So what do you think is the likely diagnosis? So if you look at the history, it's a 12-year-old with high-grade pyrexia. What do you think the diagnosis is here? What do you think this collection is? Correct. So this is an echo of a child with pyopericardium. Okay, and What are the differential diagnoses for a collection like this? So one is the pyopericardium. What else could it be? Particularly in a country like India, what is the other common infection that we find in the pericardium? Tuberculosis. So we have to differentiate between the two. And how do we do that? So basically, we send off blood tests, like the usual, infective markers, CRP, ESR. We do a MAN2, we do a TB-PCR, sputum for AFD, and of course we can aspirate the fluid and look at it under the microscope, gram stain it, culture it, to see, what the exact pathogenic organism is. But this is an infectious process in the pericardium, okay? And because of the nature of the pericardial collection, it is most likely to be a bacterial pyopericardium. So it's as opposed to a tuberculous pericardial collection. So what will the treatment strategy be? If it is a pyopericardium, what should you do? How would you treat it? How would you treat it? Quick, it's very simple. Collection of pus, correct. So, but only IV antibiotics is unlikely to do the trick. You saw the collection, right? So it needs to be, the pus needs to be taken out, right? And usually percutaneous drainage is not adequate. So usually it's an open surgical procedure where the surgeon has to evacuate the pus. Occasionally they may strip the pericardium, but often it's only a surgical evacuation and antibiotic therapy over a prolonged period of time. Okay. So, and for TB pericarditis, of course, we need to give anti-tuberculous therapy, and at least for a minimum of, with steroids. So, surgery is contemplated either when the surgeon is not able to evacuate the pyopericardium adequately, or when the child develops constrictive pericarditis as a complication of either pyopericardium or tuberculous pericarditis. Okay. These are all very easy today. So what are the abnormal findings that you see on this echo? What's abnormal on this echo? Come on, guys. Quite obvious, just very simple and obvious. I'm only asking you for the findings, not a diagnosis. Why do you say hypoplastic left chamber? Oh, okay. So you think this is the left chamber, right? Okay, let me just tell you, maybe the view is a little oblique, but this is your interventricular septum, and this is the aortic valve, okay? So this is the dilated LV, correct. So not only dilated, but also what? Dilated and dysfunctional, correct, dysfunctional LV, okay. So there is impaired ventricular, significantly impaired ventricular systolic function. And what else can you notice? Anything else striking? Of course, the gain in the entire picture is a little on the higher side. What are these? No idea? Okay, let's move on to the next slide. Okay, you're saying the endocardium looks a little bright. Like I told you, the gain is set a little high on this echo, so it's a little sort of whiter than normal. So anyway, when we see a dilated and dysfunctional LV, it's important to assess the coronaries, because what are we looking for when we do that? ALCAPA, correct. So here we're looking at the coronaries. Is this ALCAPA or is this normal? So I've just slowed it down so that we can see. This is the aorta. This is the left main coronary artery. What do you think? Yeah, it appears normal, doesn't it? So you think this child has got idiopathic dilated cardiomyopathy then? Is that right? Is that the diagnosis then? Idiopathic dilated cardiomyopathy? Dilated cardiomyopathy. Okay. Now what do you think? Okay, there is no aortic stenosis or coarctation. Now what do you think? Same patient, same coronaries. All we have done is put some color on. Are these coronaries normal? Correct. So retrograde flow not only into the LAD, but also in the LCX. Okay, let me just try and freeze it to show you what I mean. Okay. I'm not able to get it in one frame because it's, yeah, okay. So this is the LAD, okay. So the LAD normally should be flowing from the aorta towards the ventricular septum, towards the, the apex of the heart. So this flow is normally red in color. So here you see that it is retrograde. It is coming back down the LAD. Similarly, the circumflex usually should be going away along the left AV groove. But here you see retrograde flow. You see that red flow, that line of red flow, that is the left circumflex. So there is retrograde flow in the coronary arteries. So this is suggestive of ALCAPA. So although in the 2D picture you saw that the coronaries seem to arise quite beautifully from the aorta, here you see once you put the color on, you see that there is abnormal flow pattern. Okay. Of course, the ECG will also be a useful guide for you. Okay. So always suspect ALCAPA and don't get convinced easily, and you have to sedate and spend time with the patient. So this is what we saw on the 2D. But what is happening here is that the coronary is coming quite close to the aortic cusp, but is actually opening into the pulmonary artery. So you see that red flash of color, that is flow into the pulmonary artery. The pulmonary valve is actually further down. It's here, okay? Whereas the ALCAPA flow is more distal. The opening of the ALCAPA, anomalous coronary, is more distal. So sometimes this flow can be confused with either pulmonary regurgitation or a small PDA. But you can clearly make out here that the pulmonary valve is more proximal. So it's definitely not PR, and this position of the flow is not typical of a PDA. And you also know that it's in the setting of a dilated dysfunctional heart with retrograde flow in the coronary. So this is where the ALCAPA is actually opening up. Just another illustration of the retrograde flow in the coronary arteries. Okay. This is a fetal echo. What are the abnormalities on this fetal echo? I'm really sorry, the depth of the image is really poor, quite poor. Okay, so this is the thorax of the fetus. Let me just orient you guys. This is the thorax of the fetus, and within that you have the heart. Okay. here. So once again, apologies for the slightly poor quality, but I think the abnormality is still pretty obvious. So what is the abnormality? What is the abnormality on this fetal echo? What is striking when you see it? Come on, guys. I think it's relatively obvious. LVH. Okay. Okay, let me just tell you, forget that this is an echo loop, okay? And just you are scanning this patient and this is exactly what you see. There is no delay in this echo loop. This is exactly what you're seeing. What do you notice is very striking for a fetal heart. Exactly, there is significant fetal bradycardia, okay? Perhaps a little bit of effusion, definitely. If you consider this to be the thorax of the fetus, there is cardiomegaly. So, usually what is the size of the fetal heart with respect to the thorax? The normal fetal heart with respect to the thorax of the fetus. Usually it is only 30% of the size of the thorax. Here you can see it's over 50%, or maybe 60 odd percent of the size of the entire fetal thorax. Okay, so this patient has cardiomegaly, bradycardia, and also cardiac dysfunction. So the cardiac function is also not normal. So usually in this setting, what is the most common diagnosis, which you will now prove? Why is usually this significant bradycardia? Yeah, from a cardiac pathology point of view, it's usually complete heart block. Of course, this can also be a kind of a terminal sign of a sick, unwell fetus that is going to be lost because of other causes also. Okay, so we talked about the normal fetal cardiac size, which is 30% the size of the thorax. And then, do you guys know what a cardiac axis is in a fetal echo? How do you calculate the cardiac axis? And what is the normal cardiac axis? Any answers? So the cardiac axis is essentially the angle, correct. The normal cardiac axis is 45 degrees, and it is the angle between the interventricular septum and the anteroposterior dimension of the thorax, right? So if you draw a central anteroposterior line, the angle of the interventricular septum from that line, and it's usually 45 degrees and to the left. An abnormal cardiac axis is strongly associated with CHD. Okay, so we've already done this. What is the suspected diagnosis? So we decide to do some Doppler. So this is to estimate the heart rate. We see here that the heart rate is only 70 beats per minute, which is definite bradycardia in this fetus. This is an M mode that is taken through both the ventricle and the atria. Okay, so if you notice here, this is ventricular contraction that I'm pointing out. This is the second ventricular contraction, third ventricular contraction. This is the atrial M mode. You can see that there are two bumps here. Between the two ventricular contractions, you can see two atrial contractions. So the atrial contractions are going at a much faster rate, and they are completely dissociated. So normally in sinus rhythm, you will see an atrial contraction preceding a ventricular contraction. Here, there is AV dissociation. So this M mode shows you AV dissociation. This is a very useful MO trace to get in suspected complete heart block in order to make the diagnosis. So here we have just measured it. We see that the ventricles are going at approximately a rate of 70 and the atria are going quite dissociated. I don't think this is 2:1 block. This is just AV dissociation, but the atria are going at a rate of 150. Now, usually when you have such a degree of cardiac dysfunction and cardiomegaly, it is a bad sign in a fetal complete heart block. Okay. Not all babies are born with poor cardiac function and cardiomegaly. A lot of them are born with good cardiac function, pretty normal heart size, and only complete heart block. So, if you look at what percentage of fetal heart block is associated with maternal autoimmune disease, do you know what percentage is associated with maternal autoimmune disease? So if you take 100 patients with heart block, what percentage? No, it's much higher than that. It's about 50%. Exactly. Yeah, well, it's at least 50%. Okay. So at least 50% of fetal heart block is associated with some form of maternal autoimmune disease, most commonly SLE. So what are the antibodies that we check in the mother when we find a baby with fetal complete heart block? With anti-Rho and anti-La antibodies. If you take a mother with a lady with SLE, what is the chance of her having her first baby with complete heart block? So we said that if you take all babies with complete heart block, about 50% of them have mothers with SLE, okay? But if you take 100 ladies with complete heart block and they all have their first child, what percentage of them will have complete heart block? Sorry. If you take 100 ladies with SLE and they all have their first child, what percentage of them will have complete heart block? Only around 5%. Okay. Now, so the chances of a lady with SLE having a child with complete heart block is about 5%. But if it is a second pregnancy, what happens to this risk? Does it increase or does it decrease? Correct. So if it is a second pregnancy, the chances of the second child having complete heart block are higher. When the first child has already had complete heart block, the chances of the second child having complete heart block are higher. It's about 15 to 20%. So what percentage of fetuses with heart block survive to term? A pretty high percentage. Nearly 75% of them will survive to term. But this percentage drops significantly if the child has got structural heart disease. So if there is some congenital heart disease and there is a complete heart block, then this percentage drops down to about 20-25%. So what are the poor prognostic factors? Any ideas? We already mentioned one now. Yeah, hydrops is one, presence of hydrops. Associated CHT, okay? So structurally normal heart with complete heart block has a much better outlook. If you have a CHT with complete heart block, it's a poorer prognostic feature. And of course, if if the heart block is evident at a much earlier fetal age. So as far as treatment is concerned, treatment options are not that spectacular, really. Maternal steroids have been tried. They have their own complications like growth retardation and oligohydramnios. And the benefits of maternal steroids are questionable. Okay. So this is the next question moving on to. This is a patient with Tetralogy of Fallot. So describe the echo finding scene. What am I showing you? Come on, guys. What am I showing you? This is a long axis parasternal view. Excellent. So restricted subaortic VSD and dilated aortic root. Fair enough. I think we'll accept that answer. So the echo illustrates usually what do you see? You see a nice wide open VSD, right? So this is what a restrictive VSD in a tetralogy of Fallot looks like. This is the Doppler gradient across that VSD. It's 35. Okay. See, normally a standard VSD, you know, if you get a 35 gradient, you wouldn't call it restrictive. But in tetralogy of Fallot, you usually never find a gradient, right? So the VSD is usually huge. There is no pressure gradient across the VSD because the two chambers are at equal pressure. So the presence of any significant gradient like this indicates restriction. Okay. Restrictive VSD with RCC prolapse, somebody has answered. No, I've already told you. Okay. I mean, this is tetralogy of Fallot. It is a restrictive VSD. RCC prolapse, I'm not so sure. Okay. So what are the problems with the restrictive VSD in the setting of a TOF? What happens to these patients? One of the reasons patients with unrepaired tetralogy of Fallot get into trouble, right? Yeah. So they get RV failure because there is no, there is severe RVOT obstruction and there is also no release of the pressure through the VSD. They may not be particularly cyanotic. That's the thing to bear in mind. Okay. So their saturations will not be very low. Their RV will start to fail because of the pressure overload. And post-operatively also, these are difficult patients to manage because they have a highly restrictive physiology. So they are more high-risk patients and they will exhibit restrictive physiology. Okay, another echo, a typical classical kind of appearance. Okay, so let me just give you a crude suprasternal view. What is being shown here? So you see this, view, you should really, strongly think about a particular diagnosis. This is suprasternal, exactly, very good. Interruption, ductal continuation, very good. You guys are really awake and smashing the quiz today. So this kind of an appearance, okay, where, there is an abrupt ending. These are the head and neck branches. Of course, each head and neck branch has to be identified. So just looking at one clip and saying this is such and such a branch is not of much value. I can tell you that this is the left subclavian artery, okay, and this is the left carotid. This is the PDA. This is the pulmonary artery. This is the descending aorta. So what you see is that there is no aortic continuation. The aorta, ascending aorta, and arch end abruptly. So that kind of V-shaped appearance, taking off the head and neck vessels, is very typical of interruption. Okay. So what I told you that this is the left subclavian artery, that is the last branch of the head and neck. What type of interruption will this be? This is the left carotid. This is the left subclavian. What type of interruption can you call it then? Type A, very good. What is the most common type of interruption? Type B, right. So the most common type of interruption is type B, where the interruption is between the left subclavian and the left carotid. So in that case, usually the left subclavian will be here, okay, distally. But this one is a type A interruption. What is the most common genetic association with interruption? Correct. So DeGeorge syndrome is commonly associated with interruption. I think we have covered these questions. And the most common associated cardiac anomaly? VSD. Perfect. Very good. Okay. So next here, we have a 2-week-old with saturations of 85%. So what can you see here? Why do you think the saturations are 85%? Okay. See, for one thing, I think we can't Okay, Sangeeta, tell me why you're telling me this is TAPVC. Right. I accept ASD right to left, TR jet to LA through ASD. I'm not entirely sure just from this one clip we are able to say yes. I don't think, okay, so just to be devil's advocate, I will say that I can see this kind of a situation with, say, a pulmonary hypertensive neonate, okay, for whatever reason, has severe pulmonary hypertension, has significant GR, open PFO, and right-left shunting. I think just with this view, one cannot say that this is TAPVC. Okay, what you can say is you can describe the findings, and one of, I guess, the commonest or the most likely one of the differential diagnoses would be TAPVC. Okay, so what are the possible differential diagnoses? One is TAPVC. Okay. Other is any persistent, severe persistent pulmonary hypertension can cause a similar picture. So this could be just neonatal persistent like PPHN, severe PPHN can also give this kind of a picture. Okay, but yes, Sangeeta seems to be right. What are the findings here? We've moved on to the next clip. So what are we showing here? So it's a subcostal, fairly oblique kind of view. So the same patient, we know that the patient has got RA-RV dilatation. We know that there is a significant GR and right to left flow across the ASD or PFO. Correct. So we suspect that one of the differentials is total anomalous pulmonary venous connection. In this clip, we see the pulmonary veins here. At least two of them we can see, but all of the veins actually come in here. And this is a very posterior cut, okay, which looks at the coronary sinus subcostally. So here you see that the veins are entering the coronary sinus and then the right atrium, okay. And what is striking? This is not the dilated CS cardiac TAPVC is not a complete diagnosis that you have given me. What is striking here? There appears to be some degree of obstruction. Yeah. So there's a lot of aliasing of flow and the opening itself looks a little restricted. So the next step is to get a gradient across that perhaps. And we see that the mean gradient is 11, which is elevated. And also the trace does not return to the baseline or show respiratory variation as you would normally with a pulmonary venous trace, right? So this trace with a peak gradient of 20 and a mean gradient of 11 indicates that there is obstruction to flow. The pattern of the Doppler trace itself is abnormal. It is continuous, not returning to the baseline, not varying with respiration. So this is obstructed TAPVC to the coronary sinus. Okay, the next one. So what finding is being demonstrated here? And what are the possible differential diagnoses? A simple one, we've discussed this many times before. This is, who said posterior shelf? Correct. So the aortic arch is actually widely open. Okay, there is no posterior shelf or any shelf here. You can see during the forward flow, there is broad flow, no obstruction. This is not a posterior shelf. Usually a posterior shelf will be found here. Okay, I mean, maybe that arrow is a little, distracting. You ignore the arrow, okay? Right, so this is flow reversal in the aorta. The causes are either severe AR, it can be a large AP window, Somebody's mentioned PDA, BT shunt. Very good. What else? At least one more. What else? Where there is a communication between the aorta, correct. Ruptured sinus of Valsalva, a large coronary fistula, okay. So all of these are possible differential diagnoses. Okay, this is the same patient's echo. There is a, what do you find here? Simple. I'm not asking you for any rocket science. This 4-chamber view just shows a dilated LV and there is mild MR. Okay. So we have seen flow reversal. And then the short axis view looking at the pulmonary artery shows correct, a PDA. So the flow reversal is related to a large PDA and there is a dilatation of the LV. And usually this kind of flow reversal, what does it mean? I mean, in terms of operability or closability, is it a good prognostic factor or a poor prognostic factor? If you have flow reversal due to a PDA, for example, it's a good prognostic factor. So because it means that the PVR is low. That is why there is so much left-right flow and flow reversal in the aorta. Okay, so what are the findings on this echocardiogram? Right. So this is a severely dysfunctional LV with a huge LV apical thrombus. And you can see that this is an adult patient who has suffered a significant myocardial infarction and there is a lot of wall thinning in this patient. So this is not a good situation. Okay. The patient will not tolerate surgery to remove the thrombus at all if it is required. So this all you can do is anticoagulate them and hope and pray. Okay, so this 7-month-old has come to you with breathlessness. What are your findings on this 4-chamber view? So it gives a very typical history, not gaining weight properly, a bit of short. When you examine the baby, you can see that there is some tachypnea and respiratory distress. So you notice that the LA is dilated, very good, and so is the LV. So you think maybe the AML looks abnormal. It's difficult to know whether this is just a stretched mitral valve. Yeah, maybe yeah. So I didn't particularly think the mitral valve was abnormal, but okay. So what is the differential diagnosis of a dilated LA and LV? Dilated LA and LV and signs of breathlessness. I don't think the mitral valve is abnormal here. Perhaps the cuts are not very good. Okay. So, right. So you've got large VSD. Okay, hold on. So take my word for it that the mitral valve is normal. I've not shown you, multiple views, but the mitral valve in this patient is normal. Okay. So what are the possible differential diagnoses? You guys have gone very fast. I don't know how to go back on the comments, to be honest. So large, okay, you've done VSD, PDA, AP window, AVSD. Okay. So possibilities are a large VSD, large PDA. So obviously on this 4-chamber view, you can't really see a VSD. Of course, you have to examine the septum completely and you have to look for the other causes that you have mentioned. Okay. So what do you think this is? What view is this? Oops, I think I've Gone ahead of myself. Yeah, correct. So somebody did give me the answer. It's a parasternal short axis view. And essentially what it shows is there is a huge communication between the aorta and the pulmonary artery. So there's a huge AP window, large one, okay? Obviously needs surgical treatment. So yeah, this is the aorta, these are the labels, the main pulmonary artery, the RPA and the LPA, okay? And this is the actual window. So when this is closed, obviously it has to be closed like this, okay? So this is an AP window. It's not the right pulmonary artery from the aorta. Okay, RPA from the aorta. The RPA from the aorta will have no communication with the MPA. So if it is RPA from aorta, this gap will not be there. It will be two separate entities. The main pulmonary artery will be separated from the aorta. So they are different. RPA from the aorta is not the same as an AP window. This is an AP window where there is communication between the PA and the aorta. Because the AP window is quite large, it gives you the impression that the RPA is coming from the aorta, but it's not so. Whereas RPA arising from the aorta, RPA will be the only, it's an isolated thing. Okay, so this is a 10-year-old who presents with a murmur. What do you think the diagnosis is, looking at the external appearance of the patient? What are the striking abnormalities? Come on, guys. It's a very typical presentation, really. Pericardial bulge, perhaps. Okay, so the child appears to have some degree of chest deformity. Okay, so he actually has pectus excavatum. Okay, which maybe is not very obvious here, but I think it is still seen. He has some webbing of his neck, quite a broad forehead, down slanting fissures. He has a murmur, okay? This is his ECG. What are the ECG findings? He's 10. What are the ECG findings? Okay, low atrial rhythm and significant right ventricular hypertrophy. Okay, so this guy has got right ventricular hypertrophy. And you still haven't identified the syndrome. Do you accept that there's a bit of webbing of the neck? Chest deformity? Yeah, so this child has got Noonan syndrome. Okay, so Noonan syndrome with right ventricular hypertrophy. So what do you think his cardiac abnormality is going to be? Yeah, significant pulmonary stenosis most likely. So what is the mode of inheritance of Noonan syndrome? Yeah, so autosomal dominant. So you'll often find that the parents also appear to have Noonan syndrome and they may never have been diagnosed to have it. So it's important that these families are sent for genetic counseling. And what are the common lesions that we find in Noonan syndrome, apart from pulmonary stenosis? Hookworm is one. They can also have coarctation of aorta. Okay, one of the issues with patients with Noonan syndrome, sometimes the pulmonary stenosis, the valve can be quite thick and dysplastic, and it can be a little difficult to balloon dilate, or they may not be amenable to balloon dilatation. And apart from the heart, there are other important considerations like vision, hearing. Some of them are have mental retardation, and interestingly, they also have some coagulation abnormalities. So these are all things to screen for. Okay, so we move on because time is kind of ticking along. So this is a 1-year-old with a history of 2 sibling deaths. Okay, one of the siblings had some ECG abnormality, but this is the ECG of this patient. What do you think is wrong with this patient? What do you think is wrong with this patient? Okay. Yes, there is some bradycardia. Heart rate is only 60. Correct. So if you look at the QT interval here, corrected QT it says is 490, which is quite long. What we need to do, of course, is manually calculate the QT. But more importantly, you can see that the T waves are not normal at all, right? So there's an abnormal appearance of the T waves, abnormal morphology of the T waves. And this is a child who has, so there's some bifid kind of a nature and this flattening of the T wave. This is a child with long QT syndrome. What is the normal treatment for long QT syndrome? Yeah, so they need to be risk stratified first, depending on their symptoms, and depending on whether their risk profile, they either get beta blocked or they will get an implantable cardioverter defibrillator. Of course, not at this age, but in an older patient, an ICD is also a form of treatment and prevention of malignant arrhythmias along with the beta blocker. Sometimes with the beta blocker, if they have a low heart rate already and you're going to beta block them, you may need to use a pacemaker also to keep their heart rate high. So these are all the various considerations to be borne in mind. So they need to be beta blocked, but if they're very bradycardic, then they may need a pacemaker. If they have if they had a near cardiac arrest situation, and they are at high risk for sudden cardiac death, they may need a defibrillator. Okay, so this X-ray spot diagnosis. Come on, guys, you've seen this before, I'm sure. What can you see here? Eisenmenger, very good. So here you see the lung fields are very oligemic. There is a abrupt pruning of the pulmonary vasculature. You can see the central pulmonary vasculature, but peripherally, suddenly, there's hardly anything to see. This is the main pulmonary artery, which is very dilated. The cardiac shadow itself is very small, so there is no cardiomegaly, just dilated pulmonary artery and abrupt cessation of, the peripheral pulmonary marking. So this is a patient with Eisenmenger syndrome. So you have a patient with Eisenmenger syndrome and they come to you with sudden onset breathlessness. What is, one of the most important things that complications that these patients can develop, and how will you rule that out? Correct. So they can develop pulmonary thrombus actually. More than pulmonary embolus, it's thrombus in the pulmonary artery, which develops within the dilated pulmonary artery because of the poor flow and stasis plus the potential coagulation abnormalities, if they are cyanotic, etc. So what is the investigation they would require if you're suspecting a pulmonary thrombus? Yeah, so they would require a CT chest to look for, pulmonary thrombus. Okay. So this is a 10-year-old who presents with cardiac failure. What is the diagnosis? Any answers? Keep watching. So what is this angiogram? It's an angiogram in the, pigtail and the LV in LAO view. Not LV non-compaction. What do you see here? Okay. Right. So this may help you a little bit more. So this is, now are you convinced? This child has got significant severe supravalvular aortic stenosis and had depressed cardiac function. So the reason for the cardiac catheterization is, of course, to assess the nature of the aortic stenosis, which is often obvious on the echo, but also more importantly, to see if there's any coronary involvement, because often the coronaries can be quite close to the narrowing. So selective coronary injections are sometimes useful to give the surgeon some guidance as to how close the coronaries are to the area of stenosis and whether they are actually involved in the stenosis, so that he can make a surgical plan. So what treatment will you offer for this patient basically? It's only surgery. Right? So basically the patient will need a repair of the supravalvular aortic stenosis by surgery. So what other features will you look for in this patient? So what is the syndrome that is associated with supravalvular aortic stenosis? William syndrome. What are the features of William syndrome? Quickly. What are the features of William syndrome? Yeah, so it's a very typical facies, typical personality, the cocktail personality. They can have bad teeth, poor dentition. They're often hypercalcemic. Okay, so these are some of the features of Williams syndrome. Okay, describe the catheter course in this patient. And what is the diagnosis? Any answers, guys? Very good. So I saw an IVC into RA, into LV, into PA. So what is this? This is not a stemming. Yeah. So the anatomy is basically there is AV and VA discordance or congenitally corrected transposition. Obviously, you've noticed that there are sternal wires. Okay. The same patient. So what procedure has this patient undergone? What procedure has this patient undergone? Patient has got CTGA. These are the pulmonary arteries, right? Yeah. So PA banding has been done in an attempt to train the LV. So in preparation for a double switch operation. And this is usually done when there is tricuspid regurgitation which is, either new tricuspid regurgitation or worsening tricuspid regurgitation. It's an indication for a double switch operation in a patient with CTGA. Okay, so this is a patient who presents, the 2-month-old, with breathlessness. What can you see on the echo? So this is a subcostal bicaval type of view. This is the SVC. Okay, very good. Brisk flow in the SVC. Usually this alerts you to the possibility of what? TAPVC. Then you look at the atrial septum. Yeah. You look at the atrial septum. What do you see here? This is the area of the atrial septum. There is right to left shunt. So you're strongly thinking of a TAPVC here. Then you look at the 4-chamber view. You say RARV, dilatation, and some TR, right? So relatively the LA and LV look quite small and underfilled. TR gradient is 65. Okay, so there is pulmonary hypertension. Usually in supracardiac TAPVC, when there is a greater degree of pulmonary hypertension, what will you suspect? What will you suspect? Obstruction. Okay, so this is subcostal view. What am I showing you here? Where my pointer is. Subcostal view. If I can find my pointer. Correct. This is the pulmonary venous confluence, which is posterior to the atrium. Okay, and which is the most common site of obstruction in a supracardiac TAPVC? What is the most common site of obstruction in supracardiac TAPVC? Yeah, so what is called the bronchopulmonary vice, okay, which is between the bronchus and the left pulmonary artery. And this is the confluence, this is the vertical vein, and you can see some flow acceleration as it goes up. So this is obstructed. Once again, same thing that we discussed earlier, the Doppler trace does not return to the base. So this tracing itself, irrespective of the gradient, tracing itself indicates that there is obstructed pulmonary venous flow. Okay. So describe this, moving on. Describe this angiogram. No. Okay, so one of the first things you notice is the heart is quite shifted to the right. Okay, so then if you look at the course of the catheter, it appears to go from the IVC through the atrium into the SVC and then down another vessel. Okay, so this is an anomalous pulmonary vein, and you've cannulated the anomalous pulmonary vein. What is this? Aorta, PDA, PA, and all that. So this is a pulmonary vein that you've cannulated. So this is on the right side, the lower pulmonary vein has been entered, and it is draining anomalously. So IVC into the atrium, into the SVC, and into the pulmonary vein. Okay. So this is, of course, we have not described the entire cardiac anatomy completely, but this particular angiogram, the catheter course, is from the IVC through the atrium into the SVC into a pulmonary vein which appears to be draining anomalously. The other veins have to be traced. The rest of the cardiac anatomy has to be determined. Okay, but this is definitely not aorta and pulmonary artery. This is totally not into the ventricle at all. Okay, I have a feeling that we may be running out of time, guys. I'm not sure. Are we okay for time, or we? Okay, so another echo clip. What is this showing you again? You've seen this before. It's a subcostal view. Looking at the, yeah. So it shows right to left shunting across the ASD. What are the differential diagnoses of right to left shunting across the ASD? We've already seen TAPVC as one of the differential diagnoses. What are the others? Correct. Pulmonary stenosis with PIVS or PS, critical PS with intact ventricular septum, tricuspid atresia, persistent pulmonary hypertension. Yeah. And also, in some instances, Epstein's, right? When you have an Epstein's valve and you have PR, that PR jet can sometimes be directed towards the LA, giving rise to a right to left shunt. But obviously, the Epstein's tricuspid valve will be pretty obvious on echo. Okay, so this patient with right to left flow, what is the diagnosis? So what are we seeing here on this 4-chamber view? I think it's pretty obvious. This is a 4-chamber view. Okay, this is the RA, LA, LV, mitral valve. Right. So there is a hypoplastic RV and possibility of tricuspid, either severe tricuspid stenosis or tricuspid atresia. Okay, so same patient. This is the short axis view. And this patient actually has hypoplastic RV and also pulmonary atresia. So we've seen that the patient has got either critical or severe tricuspid stenosis or tricuspid atresia. We haven't put color on the tricuspid valve. If there's a trickle of flow across it, then we'll call it tricuspid stenosis. If there's absolutely no flow and it looks completely blocked, we call it tricuspid atresia. And here you have pulmonary atresia. And what is this flow? It's a PDA flow. Okay. So this patient is a 9-month-old and has saturations of 80%. What will your strategy be in terms of treatment? Nine-month-old with 80% saturations with a PDA. Yeah. And a clearly hypoplastic RV, which I think there is not much benefit rehabilitating. So initially you will have to carry out a thorough assessment. Here the limiting factor is often the size of the tricuspid valve. So if the tricuspid valve is either atretic or the Z-score is very low, then there is no point, contemplating any form of kind of RV rehabilitation. Also the pulmonary atresia here appears to be infundibular. So if there is valvar pulmonary atresia in a PAIVS type of scenario, then one of the possibilities is of course a 1.5 ventricle type of repair. But here, like you guys have clearly, quite correctly pointed out, the treatment strategy is most likely going to be a bidirectional Glenn shunt. Okay, I think we probably have already done this. Okay, so that brings us to the end of this morning session. I hope you've had a useful session. If you have any questions, I'll take that right now. Also, if there are any particular areas that you want to brush up on before your exams or whatever, I think you guys should feedback so that we can help you particularly with that.